back, guys, to episode 13 of the Scrubbed In weekly podcast. Today's episode, we're going to go back in more depth of what it's like to be an F1. So we'll start off how we picked our jobs, and then we'll talk about being an F1 in general surgery as well as being an F1 in general medicine. So, without further delay, let's start by saying, what was your motivation or your mindset or strategy, like some people say, when picking your jobs for F1 and F2?
So my strategy. So first thing first, I think when I picked the jobs that I prioritized firstly by location. So actually, I wanted to work close to home because I hate wasting time. So I wanted to reduce travel time to as minimum as possible. So then that allows me to spend more time doing whatever I want to do. And it is what allows me to do all the things that I do. And now moving on to jobs, I wanted to be a holistic doctor. So in the sense that I've got good experience in various different fields and not just the same. So I didn't pick, for example, medical jobs 3 times. For example, some people did have gastro, resp, cardio for the whole year. I wanted a good mix. And then I was tactical as well. I wanted to not feel the sort of feel burnt out. I wanted something that was less intense, maybe required a different set of skills, but it was also beneficial. So I chose surgery because I was interested in surgery at the time. And who knows, I might do surgery, but I wanted a surgical job to see what it was like to be in theatre, to manage surgical patients, the complications that come about from surgery, and all sorts. So surgery was number 1, which I got, and I ended up doing vascular surgery. And looking back, my experience on vascular really did train me up very well, right? Cannulating now, did, right? They were so difficult to cannulate. I said it on the last episode. Right now, I feel very confident in finding a vein in somewhere to cannulate. That's number 1. And then I thought, I know that surgery is intense wherever you go. London, outside London, whatever it is, it's going to be intense, right? So I thought, I wanted something that requires a different set of skills, something that takes a little bit pressure off me. So I chose psychiatry, all right? So a different set of skills. So this one was now looking after the mental health, away from the medical side of things, very well supported. And I think here now, London versus outside of London, there is a difference, right? Because I think some of our friends who were doing psychiatry outside of London said they really did a lot, if we're just honest and frank. But in London, I was on the wards, we had ward rounds and everything, but we also did clinics. So I was doing clinics twice a week. So for example, if a GP referred you in for, say, you had low mood, poor appetite, you're not sleeping very well, and he was thinking this patient might be depressed. So he would refer him to the centre, and I would be the first psychiatrist to pick up that referral and do a full assessment.
Yeah, so you get that
right. So I was doing that. I was doing follow-up clinics. So every time I saw patients regularly every 4 weeks. So I found psychiatry to be busy, but less intense in the sense I wasn't dealing with crisis situation. And if it was a crisis situation, they'd be admitted. Yeah. Right. It wouldn't be something like a deteriorating septic patient that will then arrest. Possibly, it wasn't that critical. It took some pressure off me, and it was a good time for me to do other things as well that I loved. That was the time I actually started up the social projects and things like that. And then I wanted definitely a medical job, right? Because that's essentially bread and butter as well. You need to have those skills. So I chose acute medicine. And as an acute, I didn't have a base specialty, so I wasn't in cardiology, gastro, resp. It was acute medicine. So I saw all the acute things that came through the door through A&E and admitted. And I loved that job because we'd be dealing just with the acute period of, let's say, a week. And then, say, for example, someone with COPD comes in, or chest infection, they're really, really sort of septic, really ill. We'll treat them for the first week, stabilize them, either discharge, or if they need to still stay in, they can go in under the respiratory team. So we had a very good turnover of patients, and I saw loads of different things. And I absolutely loved that placement. to the point that I'm considering medicine at the same time as well. Medicine was so fun for me. And I loved all of the SHOs, all of the regs, all of the consultants.
It's a good specialty. It's fast paced. You don't get to deal with the same patient for like 2-3 days.
Yeah.
And what was it, AMU?
Acute medicine, yeah.
So usually a day or two, and then you either discharge or you move them,
on to a different.
So you get to see lots of patients really quickly, and you're not stuck with the same stuff for a long period of time.
Exactly. F2 wise, I chose A&E. I wanted to be in A&E because A&E you learn so much. It's so fun. My eyes are red, by the way, because I've just come off a night shift. So forgive me for that. But yeah, it's so fun. The only thing is the rota is so intense.
Horrendous.
I feel like I'm at work every single day. You're doing 3-day shifts, and then suddenly you're doing night shifts, and then you're back on days. You get 1 day off, and then you're back at work, and it's just about legal as well. It is a legal rota.
Yeah.
And it's the same.
They're quite smart when it comes to rotas.
Exactly. But the thing is, in A&E, you treat everything and anything, and I love it. I absolutely love emergency medicine now. It is something that I'll consider. I don't know, I love everything right now.
That's medicine. That's
medicine.
Yeah, with specialty wise, it's like whatever specialty you do in that time, you want to do that.
Exactly. Yeah, you want to do it.
Actually, want to do the specialty time.
But it's so fun, so rewarding. I'm working with a great bunch of doctors, SHOs, consultants. Everyone's so nice. I love the unit, and I picked GP. Because GP is one of those things that I will always consider. I won't close the door on that. I've seen loads of happy GPs around doing loads of different projects, teaching, going abroad, charity work. So it's one of those things where I want to experience what it's like to be in a GP setting. And I ended with cardiology. So that I did my BSc in cardiology.
So that'll be good for you.
So I had an invested interest in that. I want to see what the cath lab is like and all of those things. So yeah, that was my idea. So I chose essentially things that I'm interested in, things for my learning, and strategically things where I'd like a little bit of pressure off me after an intense period. So I'm hoping GP over Christmas would give me a little bit of a break. So yeah, what about you? How did you pick it?
So I did something similar to you. So for me, the location thing wasn't that important. So obviously I'm out in Coventry, so wherever I go, I'm going to be living now. So what I did was basically, you have to do gen surg, gen med, but you can choose what specialty in that.
Yeah.
So for general surgery, I did upper GI. I didn't want to do colorectal. That's to do with like all the poo stuff.
You've always hated that.
Yeah, and like, I can't stand the smell. It's difficult, so I did upper GI. My consultant was upper GI, so we did loads of like gallbladder surgeries and those type of procedures. Obviously, there was still some colorectal. When we had emergencies, you can't really do anything about that, but it was a lot of upper GI stuff. For general medicine, I did endocrine because I loved endocrine throughout medical school. It was between endocrine and respiratory medicine. Those are the two specialties I enjoyed the most. I ended up getting endocrine, which was amazing. I think it's one of the best rotations I've had so far because the reg and the consultant were amazing. If there was a really good patient, he would stop the ward round and turn it into a half-an-hour teaching session with that one patient. Bear in mind, he's like a clinical director of the hospital now, so I was really good. I see him as like older brother's my reg, and the consultant was senior consultant, clinical director. So I got really good with the management of the hospital. So that was good. Then I went on to do genitourinary medicine, HIV, infectious diseases, which was super interesting. Like HIV was amazing. So what I did, similar to you, is basically, and this is one advice I give to people, is don't pick 3 busy jobs back to back. So having 3 really busy jobs in F1 and then 3 busy jobs in F2. Otherwise you will just burn out, and it's very difficult once you burn out to kind of get your footing back in again, and people are really tired and they don't feel they've recovered before they jump to a different job.
And some people want to sit exams.
Exactly.
So you want to be able to have time away to revise. So I know some people who chose some more relatively chilled out jobs just to be able to revise for their MRCP or something like that.
Yeah. So I know a girl who's doing a chill back job. So when we say chill back job, there are certain jobs that it's not as intensive, or the day-to-day running is lighter. There are some jobs where you don't need to do nights, you don't need to do weekends. There are some jobs where you don't have any on-calls at all. So what I did is basically I ensured I had 2 busy jobs just for learning wise, and then I have a non-busy job, which was the genitourinary medicine for F1, and for F2 it's GP, which obviously I might pursue. But I did the light job per se in the summer, because obviously I want to come back, because I come back to London every weekend and whatnot, and I wanted to maximize my time, so I wanted to enjoy summer properly. So when you have a lighter job, it's easy. So I don't mind working hard for at the beginning of the year. It means I can end the year as a lighter job. So it doesn't mean 8 months I'm just running around. So that's the way I did it. For F2, I did Obs and Gynae. So for people that know us, we set up the Maternal Aid Association. So we set up the charity helping mothers, and I thought kind of growing that, managing that, having a background in Obs and Gynae would be good for both here in Bangladesh. So that was purely the reason as to why I did Obs and Gynae. And we can give a whole series or like a whole episode on Obs and Gynae, or specialty per se. So that was for the charity. I did GP for, obviously wanted to pursue GP, and I did ITU because ITU was something I didn't get exposure much in medical school, and it was just I found it interesting. Just, you know what,
really sick patients, that'd be
and I thought,
you know, job.
For me it was, I haven't done it yet. I'm going to be starting it soon. It's just being able to manage the most unwell patients in the hospital. You get to pick up lots of clinical procedural skills. So I'm looking forward to ITE. It may be the biggest mistake I've ever made, or the best thing I've ever done. And my rota is similar to yours. So like each shift is 12 hours, and it's just you merge days to nights to weekends to nights to days.
There's
to
no
weekends.
such thing as weekends.
Yeah, it becomes a blur. And I know the F2 that's doing it now, and she was like, basically, your life isn't like, you know,
there is no life.
There is no life.
There is no life.
So I'm looking forward to IC. It's a very difficult rotation. Not everyone gets the opportunity to do it. So I'm kind of grateful. I'm doing it at the major trauma centre in Coventry, which should be good. So my advice in terms of picking jobs would be, pick jobs you're interested in, pick jobs that you have a skill set that you can learn, and pick a job where you might pursue in the future. It's a good way to learn, see what you like, see what you don't like. And there's no harm if you get a really bad job, or you get a job that you didn't want, at least you know you didn't like it. It reaffirms it. I think you might realize, do you know what, I liked it. So that's good. And I would say pick a job where the on-calls are not as bad, or you might not have to do weekends or nights. So at least once in F1 and once in F2 you have some time where you can relax, chill back, and you enjoy it. You don't want to be burnt out and then struggle, go into specialty training. So that was my reasoning behind picking the jobs I did, because I wasn't too fussed about location. Would you agree, or would you want to add anything?
No,
else?
I agree with that. That's how I think it should be. You have to be tactical. You have to be tactical. Do the things you love, do the things that give you time, do the things that...
and you're about to... And the way the system is, or what I've noticed personally, is some of the popular jobs are always tied in with the least popular jobs. Otherwise, you have people picking all the best ones and not getting it. The only job I missed out on, or I wanted but I didn't get, was A&E. But I got ITU instead. But more or less it's the same. So you would always get jobs that you don't really want. But that's fine. So we've kind of talked about picking jobs. Let us know, send us an email, give us a message on Instagram or whatever, and we can tell you what the job kind of entails. So what would you say is like a day we can talk about general surgery, general medicine. It's more or less the same thing really. What would a day-to-day be, or what is the typical day of an F1 in general surgery? So how does it start? Like, what time do you need to get in? What does it entail?
So in terms of general surgery, so most shifts I had to be there by 8 a.m. and some shifts by 7 a.m. Right? The 7 a.m. shifts I'd be there because for 1 hour I'd be doing surgical bloods. So I'd be taking bloods from everyone that needed
for an hour.
Day surgery for an hour.
Didn't you have like phlebotomists that go around?
No, so for some
reason...
You were the phlebotomist? We were the phlebotomists as the F1. So 7 to 8.
Bloody hell,
if you were on that shift, you were doing phlebotomy service. So for a whole hour, all the surgical bloods for all of the patients. And it was time pressured because these are day cases, so they'd be seen quickly by the anaesthetist, by the surgeon, and taken in. There'd be cases, right, where...
So they're pre-op bloods, basically.
Pre-op, yeah. Fine. There'd be cases sometimes, right, where I'm going around, the anaesthetist has seen, the consultant has seen, and the patient has already gone theatre, and I'm running to theatre like, hold on.
To get blood.
Yeah, quickly put it in theatre and take the blood. So there'd be moments like that as well. But yeah, so when I'm on the wards, the first thing you usually do, and by the way, things that we're going to say now, it's important because med school doesn't teach you this. So when I have final years shadowing me, I usually say, look, in terms of medicine and surgery and OSCEs and all that, you're probably going to learn that from everyone and anyone. learn the job now because this is what you're going to do, and it will make your life easier. So the first thing I do, you'll walk in and make sure you've got a list. I make sure that the list is updated. So by that I mean the patients who are under our care, a nice spreadsheet essentially that says patient name, details, what they have, the latest scan results, and I have a little box that says what jobs I'm going to do today, or what jobs we've done, ticked off. And the reg is like that as well, because they can then read off quickly and report. So I make sure that's up to date. Make sure I've logged in, make sure I've got everything ready, and then take the trolley once the consultant or reg is here or the SHO is here, take it to the patient bedside. And as an F1, your job is predominantly to document the consultation and to, take down the jobs, make sure you do the jobs. That's it, essentially. Read out the obs, so make sure you grab the patient phone. By the way, consultants and seniors, they love a proactive person. If you're constantly lagging behind, they become irritated. So tip number 1, make sure you're running ahead.
Be ahead of the game.
Be ahead of the game. Grab that note and say, look, this patient's not got a fever, apyrexia, blood pressure stable at 120, whatever. They love it. They love it when you do that. And I used to try. At first, admittedly, I was lagging behind. And eventually I realized, oh, wait, hold on. Let me just grab the notes and everything and do it. And I document. Documenting was another thing that medical school doesn't teach you, and I learned on the job, because at first I would be typing essays, literally typing everything down, and then even typing mistakes down. I think one of my regs once said foot clinic to be booked. He had a bit of an accent, and I wrote food clinic.
Food clinic.
I wrote food clinic to be booked, and then I wasn't asking questions. So I was like food clinic, and
that's the thing in the beginning. You don't question it. You just literally hear it
and record.
You just record.
Yeah,
you don't even question it. Your consultant can be like saying the most right. Obviously, they're not gonna be saying the most.
Yeah.
But you just like you're turning to a machine to a certain element. You just
like them
scribe
in the courtroom, just
a
scribe. Yeah.
Not registering anything and just banging it out.
Yeah, and then so. When he'd say, so what's the plan? And then I'd be like, booking the patient into a food clinic. Food clinic? What for? And I'm like, to probably check their diabetes or something, their diet.
You recognize, then you justify
I'm trying to justify it now to him. And he's like, I said foot clinic, you're in a vascular surgical firm. We looked at gangrenous toes. So there'd be lots of mistakes at first as well. And eventually one of the regs took me aside and actually said, ask us questions. When you don't understand, ask us, because then we know that you've understood. Otherwise we assume you
understand the question. That's the thing.
And I would say definitely, if you don't understand the plan,
and they don't mind it. Like you'd be surprised, like asking questions. By virtue, medics or doctors, they love teaching. It's innately that we love teaching. We love kind of passing on knowledge and whatnot, especially from experience. And like I said, being proactive is important, but asking questions, why are we doing this? Why do we not do this? You may have learned something in medical school, but when it comes to practical or a real day-to-day life, it may not be the same. It's like, you maybe I wasn't going there, you hear about VQ scans and perfusion scans and stuff like that, but we still booking people for CTPA, and you remember med school, never do a CTPA on a pregnant lady.
Exactly.
So these are the things that, the one thing that medicine has that I kind of like, that other careers don't have, is as a registrar or middle grade doctor or as a senior consultant, they are consultant because they have seen thousands and thousands more of cases than you have. Whereas other careers, you may have worked in the industry for 20 years, but you can have a graduate fresh out of university become your manager, become senior to you, and they can be half your age just because they did a degree or they did an MBA or whatever. When it's medicine, you don't have that. Naturally, everyone who is senior than you has more experience than you.
I think that's what it is. It's experience rather than where you got your degree from or anything like
skills,
that.
Of course, we don't have that. It's based on experience. How long have you been doing medicine for? The exams you've passed, and you increase your specialty. So it's very rare for you to have a consultant unless you entered medicine later, or you did it as a graduate, or you took some time out, or you had a different career, for you to have seniors that are like younger than you. Most often they're older than you, they're more mature than you to a certain degree, obviously, but they have seen more patients. So that is the advantage, and that's something that I've noticed and found. So asking questions is very important, and you learn a lot more than just seeing and doing.
And then so you'd go around each patient as the F1, you document, make sure you say all the obs and whatever the consultant wants, make sure you document down. sometimes the consultant would say, can you tell me about the bloods, or can you bring out the x-ray or something like that. So it's important you know the system. At first, obviously, I was slow because I didn't know the system. But that's part of the job, part of the learning curve. So you'd see all the patients, you'd go around, and then it comes to now doing the jobs. And this is where now, again, medical school doesn't teach you. For example, which jobs do you do first? Get the scans done early morning, because you want that information to be available by the next day if they're going for theatre, or by in the evening. It doesn't make sense to do, maybe sometimes if they need an urgent scan, to do, let's say, the bloods and send them for something else, and then book a scan for the following days, because all the slots will run out. So it's a competition essentially between all the F1s in every single department to finish their ward run and quickly get on the phone and get a scan booked.
That's important. I learned that from a reg. So like, it's important to like. So I was speaking to one of the GP trainees, and he was saying like, what's a good way to be efficient? At the end of the day, you will all find out your own ways of doing things. You'll find the best way you work. But one of the reg taught me, and he was a colorectal reg, like a trainee, and he said, always book scans in early. Because we do a lot of ultrasound, especially the gallbladder. So he said, always book in the scans early before anyone does. So he said, don't pick up the phone, go to the ultrasound department, go to the radiology department, go wherever it is, make friends with them and book your slots, because there's a certain number of slots, and if you take it, you don't need to bargain. You're basically empty slots, like, I've got XYZ patients, can we ensure they get a slot? And then later, if it's an emergency, people get moved in and out. But it means that you know your scans are booked. And what I usually do is like, I'll go back up to the wards, or go back to the nurse and say, look, she's having a scan at 10:30, she's having a scan at 11:30. Do you know what I mean? Whereas other F1s and other doctors will be rushing and they will do scanning. So I usually book my scans first, then I do my bloods, and then I do my referrals to different specialties. In essence, those are the main bulk of the jobs, because like I said, scans affects management, bloods affects management, but you can do bloods by yourself any time of the day.
Exactly.
Whereas do things that you're reliant on other people, and specialties can come review the patient in their own time. You're not going to make them rush to do it any time sooner than they are. So that is one tip I give to all prospective F1s, F2s. Scans first, blood, then special reviews, and obviously things will pop up as they do
in between. So that's a normal working day when you're managing the long-term care. So that's not on call. When you're on call, you're managing sort of the there and then situation, deteriorating patients. I think that sums up my typical, and I do obviously do, like you said, do the bloods, do the scans, make the referrals. There was one thing that we used to do that at first I was just like, what? How do you expect me to know? So we used to have like a board round after the ward round, and I would go as the sort of representative of the firm, and then it would be physios, nurses, everyone sitting in a room, and they'd look towards the doctor in the room to say, when do you expect this patient to be discharged? And at first I was like, I don't know, they've got a gangrenous toe, they could be here for 3 months if they want. But they were like, no, give me a day, and the pressure would be on. So I won't even lie, I used to just make up numbers. At first I used to be like, we have 3 weeks, 2 weeks, and then when I'd say like really crazy numbers, they'd be like, what? Why?
They love that why.
And for example, sometimes I'd just say, they'll be here like 14 days.
You don't need to 2 weeks. There's a lot of freestyling in it.
And they'd be like, what do you mean 14 days? For what? Like, we're going to chop off their toe, innit? And then they're like, 2 weeks after that. And then they'd be like, no, that's not 2 weeks, that's a week. Okay, they'll be out.
You learn very quickly how long you anticipate patients to stay. But with the board round, I remember we were on the wards, and this board round, and I could never ever remember, like, and you'd be like, all the regs and SHOs consultants would like see their name and they knew what they came in for, they knew their plan. I could never ever remember for some reason.
I couldn't commit to memory.
For some reason. And that piece of paper is like gold, and it is very good. And I think it's just everyone does it. It's like you have your patient list, what they came in with, what's the management plan, all the most recent investigation bloods, and a to-do list basically. And I remember like that is like, I needed that because it's very good. It's very, I think as an F1 is very important, like Amz said, is learn how to document properly. Documentation is super important. Document in a very legible way. And one thing I did is I learned documentation from seeing other entries. I see how other people did it. Even on calls, I never knew what is the right documentation. Do I write too little? Do I write too much? Am I writing what's important, what's not? And I used to see most often, you would see other people see other patients on calls. You'd be like, okay, so this is how they did it. This is the format, and you take the good. So whatever they did, you can replicate and find your own way. Once you know your own way, it's good. So you can always see what other people have done. So good documentation is important. Being kind of efficient, proactive is good. And I remember for us, we used to have like a team of F1s under general surgery, and we should help each other. It's very good becoming delegate, being able to delegate.
Being able to delegate.
So
being a delegate.
So, but then this goes about society work and doing startups and charity and XYZ, because you learn how to be a leader, you learn how to manage a work list or tasks, and you delegate. It's gonna be the Bainham word. Say delegate. And I remember as an F1 doing general surgery, I identified like who did what, who was very good at what, who wanted to do X, Y, Z, and I'd be like, all right, you know, when you're seeing 40, 50 patients, you can't do it physically by yourself.
Yeah,
so help
can't.
other F1s, and they will help you when you need help. And they'll be like, okay, do you mind doing this, do this, and you kind of manage it all. And then when it's their turn and they got their 30, 40 odd patients, they will give you jobs. So it's good to have these skills, because it'll be easier to do it. Regardless if you don't, you know, you've gone through medical school, you're towards the medical school and you haven't done anything, you will naturally pick up these skills.
You will,
but never burden yourself. Don't feel like you can do everything by yourself. Ask for help. There are other F1s, there are other colleagues, your reg seniors. And remember, my reg said to me, is like, don't think they can't help you. Don't think they can come and do a cannula, because at one point in time, they themselves was an F1 or F2 or house officer, senior house officer. So that is there. So a day-to-day job is basically that: booking scans, taking blood, speaking to specialty teams, preparing them for theatre, so preparing them from operations, looking after their recovery, and kind of building them up or getting them better to be discharged.
Yeah. And
then once that bed becomes free, someone else comes in and you repeat the cycle. And if they get unwell, you help them.
Yeah, and in between it's just interspersed with, I guess, if they're in a crisis, if they're in pain, if they're suddenly bleeding or their heart rate's going up, you'd be seeing them, stabilizing them, asking the SHO for help, or the reg or the consultant, flagging things up as and when needed. That's a usual day for an F1 on the wards, doing the ward jobs.
Yeah. So as an I think it might be worth just talking about F2 since we're talking about the difference, or what I've noticed as a difference between F1 and F2. The jump is, for some specialties, the jump isn't that big, because a lot of the F2 rotations are specialties. So you most often, some of these, like Obs and Gynae is senior led, so you wouldn't have someone who's been a doctor 2 years managing pregnant women. It's senior led, so middle grade doctors and above. But as an F2, the responsibilities increase, so more is expected from you. So you're not a baby anymore. They expect you to know stuff. You get to run your own clinics.
F2.
Yeah, so now I have my own clinics. And like before, you could do up to a certain, you can do X amount of things before you're allowed to call for help. Not before you're allowed to call, before you're expected to call for help.
It's the expectation.
The expectation. Right, so now as an F2, you're expected to go a bit further, do a bit more level of management or more interventions, and then call for senior help. And it's more, more responsibilities, and it's the other things, like, for me now in obstetrics and gynae, it's basically assisting more in theatre. So when I'm doing emergency C-sections, I'm going into A&E and kind of, so Amz is in A&E, so he might have a lady who comes in who's, who may be pregnant, who's having some, bleeding, maybe going through a miscarriage. So he will call the Obs and Gynae team, and then I would go and I would see the patient, and then I would decide if we discharge her or if we admit her.
Exactly.
Whereas as an F1, you wouldn't be doing that.
Yeah, you wouldn't have that
specialty, because you wouldn't. Do you know what I mean? So that's an F2. Saying that, for medicine, they do let you. So that's general surgery. So general medicine, when I did endocrine, I had shifts where I would clerk as a junior in A&E. So same again, Amz as
I did that as an F1
SHO would do. He'll clerk the patient, and then they decide essentially if it's medical, surgical, or how do you
as
in
A&E.
Yeah, and then I would see them from a medical point of view. Because you refer, isn't it?
But you work them up, isn't it? So for example, you can clerk a patient in. As an F1, I used to do this as well. So you clerk a patient in, and then as an F1, you would discuss the patient. But as an SHO, you'd clerk the patient, examine the patient, you then order the necessary investigation. So when you do make the referral, say for example, if I've got a person with pneumonia, right, I've done the bloods, I can say the white cell count is up, they've got a a higher CRP. An SHO in ED, what they expect, right, is so you see a patient from essentially picking them up through walking through the door. You see the patient, you order the necessary bloods, you order the necessary imaging, you come up with a very narrow, or you try to even pin down the differential, and you essentially can decide whether the patient can go home or not. I think as an F1, when I was clerking patients, the patient would always be reviewed. Like as in they would physically go and see them. Now, as an SHO, they expect your judgment to be accurate. So they got you to go through every single case with them, right? And then they would say, so what do you think? And if you said the patient can go home, they would trust you on that, yeah? So that's the level of responsibility you have as an SHO. And I've absolutely loved that responsibility because it's also taught me to be thorough. I also have I've got a practice of, and it's encouraged amongst F2s especially, to ask for advice. So I would ask the reg or the consultant, look, a patient has come in with this, these are the signs and symptoms, I have done bloods, I've done x-ray which shows this, I think it's this, do you think I've missed out anything? And during my first week or two I did miss a few things, and they would say, oh, don't forget this, don't forget to rule out that, don't forget to check
so
this.
Stuff like that is cool.
And so you learn and you build confidence and you get better, you get slicker, and that responsibility really does, it's empowering. It's empowering. I feel like I've learned loads on A&E. I love the job. The rota not so much, but I love the job, and I've learned so much and I've done so much. You suture, you plaster, you do loads of different things, everything. And then you're always talking to different teams. If you're in resus, I'd be calling ITU doctors, or you call an anaesthetist, or what have you. You, for example, sedate patients to put their hip back in or reduce a shoulder or whatever. And I think as an F2, there's so many opportunities that you can now take up because you're that one level up, your knowledge is that little bit better, your experience is that bit better and more. So yeah, that's the level of responsibility I have currently, and I love it. I love it. I think, with any particularly, it's one of the specialties everyone would love to do. It's like one of those dream specialties, and over and over again, the one thing that kind of stops everyone from doing it is basically this rota, this infamous rota where there is no structure, there is no day, night, weekend, and a lot of people, I think in the beginning in med school, they start in a certain way, but then they get married, then they get family, then they get kids, and then they realize, how long can I continue being like this? How long can I act like this? And it's just not medicine, it's every other career where your priorities change, and as a result the lifestyle or your work-life balance changes, and you hear lots of trainees who've kind of gone up. I had, when I was doing general urinary medicine, HIV medicine, a lot of the doctors there were ex-obs and gynae doctors. I remember one of the regis or the middle grade doctors was saying between her and her husband, 25 days of every month, one of them was on call. Oh my God. So more or less the month one of the parent was missing. So she kind of took a hit and said, you know what, I can't go on for this, I've got young kids. And she left that to do general urinary medicine, which is an extension of gynae per se. But yeah, priorities change, and it's important that you keep an open mind, don't restrict yourselves, and be open. Don't think I want to be a surgeon because you're a surgeon from third year of uni and then you don't give anything else a chance. You may realize that you may like something else. And it's also important, one of the, like an ST7 just to become a consultant said to me, it's like, just because you like a specialty, you have to also understand, is that personality of that specialty in line with yours? Because surgeons act in a certain way, medics act in a certain way, GPs act in a certain way. So although you may like it and you may think about it, is that specialty in line with your personality? Exactly.
And
as well as that, do you love that specialty, that when it demands something, you can give it? For example, surgery especially is infamous for this. The guys that really, really, really love surgery, you'll find that on weekends off, they're in theatre. They've taken annual leave, and where are they? They're in theatre. When the day shift has finished at 5 o'clock, they've asked what operations are going on, and they're in theatre.
Even in the obs and gynae, with like all these new trainees, after a night shift, they'll stay in them, like they'll hand over at 8:30, and then they'll go straight into theatre to do C-section.
Exactly.
They'll do like, you know, pelvic floor repairs, all this different stuff. But that's the level of commitment you need to have, and it's kind of inspiring, and you know.
And it varies from specialty to specialty, on what it demands and what it asks for. Yeah,
definitely. I think we kind of went off tangent, but that's fine. We're supposed to talk about the day-to-day of an F1. Hopefully we've covered it, and for the people that are final years or close to finishing med school and want a bit more insight into what it is to be an F1 or some tips and tricks, at least watching this podcast will help you. It's probably, you know, a good time to wrap it up. So we can give 3 pieces of advice for the incoming F1s, or, you know.
They're kind of 2 months in, man.
Okay.
They're 2 months in now.
So, final year medics. So, 3 pieces of advice. I'm going to go first because I want to say the good one. When you're in trouble or when you're really stuck, always escalate, always ask for help. The system is designed in such a way there are senior colleagues, senior doctors who can help you. Don't feel like you have to do everything by yourself before you can ask for help. Secondly, look after yourself, you know, mentally, physically, emotionally. If you're unwell, if you're not doing too great, there is no way we can expect you, or you can expect yourself, to go and deliver and look after patients. And, you know, give yourself breaks, make sure you take time to hydrate, drink water. And the third one I would say is be organized and efficient in the way you do things. Initially, you will be slow, you will be staying back, but that's only because you're new to the system. And as you do it more and more, the more cases you see, the better you become at identifying, and the better you be initiating management. So those are my top 3. I'm sure there's loads, but
those are our top 3. All right, you've taken majority of them. Those are our top 3. As usual, we'll leave a note in the description, and with every episode, we always put into timestamps. So if you want to skip to a certain point, you can go to that. We'll also put our 3 pieces of golden advice, golden nuggets, and you can have a look at that. Let us know what you think. And like Amz said before, leave a note in the comment section on what type of guests you like, and more so if there's particular topics. It doesn't have to be medical related, even if it has like a medical underlying theme, if something you've seen in the news, or there's certain things that you want to talk about, or maybe it might be a non-medical related thing but you want an opinion from 2 doctors. It'd be quite cool to do something like that. You know, maybe you saw something. Definitely. You know, and we can, you know, take it from there. But thank you ever so much for continuing to support us as we are growing, and we'll leave it there for today, and we hope to see you again next week. See you then otherwise.
Oh.